Welcome to Spokin's Facebook Live. Happy May, everybody. We are kicking off Food Allergy Awareness Month with a special topic and a special guest. For anyone who doesn't know, we're Spokin, and we are the platform for people living with food allergies to live the fullest life possible. And one of the key things we want to do is keep you in the know. And while food allergy parents in particular are like ninjas, we have so much to learn when you're diagnosed. You only have a few hours to really become experts in putting something in your child's mouth. One of the topics that we find is so perplexing, even to me, is IgE testing. And what is it? What does it mean? There's so many questions. And for us, as we talked about all the questions we had, we went directly to the source, to Thermo Fisher Scientific. And Thermo Fisher Scientific, if you are getting a blood test for IgE, chances are they're the ones doing the testing. And so we felt that we had questions, we went to the source to answer, and we're so lucky that we have with us today Dr. Lakiea Wright, who is here with us, she is the medical director, I want to get that right, medical director at Thermo Fisher Scientific, also a practitioner, and has flown in to give everybody who follows Spokin, her first-hand account of answering some of the questions. We did a really robust piece. I think we answered 42 questions. It's one of the longest pieces we have done. We try to pack it with so many questions that we had. I'm going to give Dr. Lakiea Wright a chance to introduce herself so we know a little bit about her background, and then we can dive into answering all the questions. So just tell us about yourself.
Thank you. So my name is Lakiea Wright. I'm a board certified allergist, and I come from a background of seeing adults and kids with allergies in both academic center and then private practice. And now I've transitioned over to work for Thermo Fisher Scientific as their medical director, and I've been working here for a few months. And my goal is really to improve education around testing and improve access to testing.
Wonderful. So I think, for us, what we're going to cover, so everybody understands, we're going to cover some of the very basics about it. Just kind of the what for people who are newly diagnosed, or a refresher for those who have been living with it for a while. The big question that we want to tackle is interpreting results. So that is one of those big ones we want to understand. Recommendations on frequency, accuracy, which is another big one that people want some questions answered about. And then my very, very favorite, the star of the show to me, is component testing. And I'll just point out on component testing, I've been an allergy mom for 12 years, and only recently learned about component testing, and only recently learned about some of the particulars and how beneficial it could be. And when we started asking people who actually knew about this, it's pretty stunning to realize how many people didn't know about it. So we're super, super excited to touch upon that. But first, we're going to start with the basics. First up, there are several tests that are out there that you can test for food allergies. Can you just give us the lay of the land? What tests are available?
Yes, so there is blood testing, and that testing is based on immunoglobulin E. That's what your body just makes in response to an allergen. And then there's skin prick testing, and that's where you puncture the skin and with an allergen, and then you see, again, the level of IgE that's being produced by a hive will show up if it's positive. And then we have additionally component testing, where it's again another blood test, and you're actually looking at the parts within the whole allergen, and that would be the difference between skin prick testing and the blood testing, because they look at the whole allergen, whereas component testing is picking apart the different parts of the allergen, which different parts are more likely to contribute to someone having anaphylaxis.
That makes sense to us. And just for way of background, how long, so you use a long word, but I'm going to use IgE.
Yes.
So how long has that test been around?
So that test has been around for a long time. Our ImmunoCap has been around since 1974 for testing food allergies, and it is the gold standard of testing. And
then of the foods it can test, like how many foods can it test?
So there are about 160 foods that can test, but about 90% of all food allergies are related to the 8 big food allergens: milk, egg, peanut, shellfish, fish, soy, wheat.
Okay, so now we're going to switch to interpreting results. So I think one of the things that happens when you in general, like if your child has a reaction or you think they have an allergy, you go to the doctor and they often tell you to get this test done. The test gets done and then you have to figure out what does it all mean. And so one of the things that we would like you to address is, there's two different types of information we tend to see. Sometimes it's a class number and sometimes it's this other number.
Yes.
So can you explain what those two things are?
So what's most important is the numerical value. So the higher the IgE level, the more likely you are to have a reaction when you're exposed to that allergen. The lower the number, the less likely it is, potentially. But in some cases, any level could result in a reaction. So that's why it's important to look at the specific food allergen, and that's ordered in the context of the patient's clinical history. So first thing is your healthcare provider has to take a detailed history, and then they have to look at what potential allergens are potentially causing the reaction, and then that's how they decide on the testing. And testing is so important in monitoring the levels because it can help us decide, depending on the level, if it's low level or higher levels, if it's in the context of clinical history, it can help us decide, should we proceed with what we call the food challenge, and that's where a patient is given small incremental amounts of food over a course of time, so that typically 3 hours, and then you're monitored to see if you're having an allergic reaction. So I'll just give an example here. So, for example, the way you would read this is if your child has an egg allergy, they have a reaction to egg, for example, hives, shortness, breath, or wheezing. And then over the course of time, you look at their egg allergen and it's 0.6. Now, if you were to reintroduce egg through this process called oral food challenge, there would be 90% probability of a negative reaction right in here. But then if the lab result is 6, you would not want to do an oral food challenge because there's a 95% chance that the child would have a reaction. Now, again, there's a huge gray area. And so that's where, as a practitioner, I like to use components because they can help clarify. When you're doing component testing, we'll talk a little bit more about the details. When you're doing component testing, there are certain parts that if it's high, then it's more likely, or positive, it's more likely that you can have a systemic reaction, also known as anaphylaxis. And so again, every time we're doing this testing, we're looking at whether it's low or high and deciding, do we have to label this child or adult with a food allergy? Can we actually introduce the food in a safe way? And if the level is low, that's a maybe, because 90% probability of negative reaction. But if it's high, for example, an egg 6 or higher, no, you would want to hold off on introducing the food. And similarly, since each allergen is different, milk, peanut, and fish, we have these established cutoffs so that we can help make these sort of decisions. Because again, you don't want to inappropriately label someone with allergy if they can in fact tolerate the food, but then you don't want to then give them the food if it's unlikely they'll tolerate it. And so that's where the numbers come in, but the numbers are specific to each food allergen. And this is established in clinical studies using ImmunoCAP to help aid in the diagnosis of food allergy and decide, can we safely introduce the food?
So 2 things to clarify, and this is for me, and I'm going to just say, I feel I'm fairly educated. I'm fairly educated in food allergies, and yet it's confusing to me. And I think what we're clarifying, one thing I just want to confirm is when you get your blood results and look at the numbers, one thing is that what a number looks like for egg, a 6 for egg is not the same if it was a 6 for fish. Each allergen, the numbers, it's not exactly the same. So they have their own kind of range.
Yes, they have their own range for predicting whether or not, or predicting the likelihood of reacting. And as you can see, these numbers vary. So for example, if we move on to peanut, that allergen can be a little tricky. You see, we don't have, this is a good example of, if it's positive, then a reaction can occur, even if it's as low as 0.1. See, there's no low level here. But then when you compare that to egg, 0.6 less likely to have a reaction. So that just highlights how it's very different. And there's this huge gray area, and that's where component comes in, because it can help us further refine, I like to say refine the diagnosis, and that's how I talk to my patients about interpreting results, because again, I'm using a combination of information to arrive at, do I need to continue to label my patient as allergic? Because I don't want to hold back, for example, a child who's labeled as peanut allergic if they can in fact have peanut.
Right.
But then if they are allergic, I do not want to give it to them, and that helps me decide.
And then the other thing to point out is right now it's only established for egg, milk, peanut, and fish. So not tree nuts, not soy, not sesame. Those are not established yet. Correct?
There hasn't well established, not as many studies with the cutoff points.
Okay, so that's super helpful. And then I think the other point to really make really clear. So a lot of people you hear say, you know, our numbers are off the charts, and they feel that the type of reaction, you know, that means a more severe reaction. Where I think what we understand is it's just an indication of like the likelihood of reaction, not the severity.
Yes, exactly. The IgE level does not predict the severity of a reaction. It's about the likelihood, as you stated, Susie, the likelihood of a reaction.
Okay.
Yes.
And the phrase that we use, specific IgE, the distinction is specific to the allergen. So specific is your IgE to egg or milk. And then there's a concept called total IgE.
Yes.
Do you mind explaining total IgE to us?
Yes. So total IgE is the whole IgE in your body, but it's not specific at all. And so when we're talking about food allergy, it's much more relevant to talk about the specific levels. And as we demonstrated here, the ranges mean different things as far as trying to decide can the patient go on to receive a food challenge.
Another question, you know, I think we just got a question, and it's such a big question. You're an allergist, you know, you see patients, you saw patients. Do you always recommend a blood test? We personally, as my family, stopped having my daughter. I'll just share my personal story. We stopped having her get a skin prick test because she was so upset. It was very aggravating to her, for us, for our family. And so we just stick with the blood test. I'm curious, like your recommendations for your patients, is it right for everybody essentially? And do you always recommend it?
Yes, so in my practice, when I'm seeing patients, I tend to use blood testing plus skin prick testing to arrive at a diagnosis, because again, blood testing and skin prick testing, you're using it to help you aid in diagnosis, but the most important thing is to understand the reaction, understand what happened, so that you can hone in on the appropriate testing. Now, one of the advantages of blood testing is that if you're on something like antihistamines like Zyrtec, Allegra, or Claritin, you actually can't get the skin testing. And I see a lot of patients, they will have what we call allergic rhinitis or hay fever, and so they can't come off their medications, but I don't want to not test them, but I can, so I can get the blood test and sort of get around the medications by doing the blood test, because it isn't affected by that.
And just to go back to the question about classes, so I think you see some people say, I'm a class 2, I'm a class 3, and I think what you're saying is you're really trying to gear people towards looking at the numerical number.
Yes, looking at the numerical number. Now, understand where classes come from. It's an attempt to sort of break it up into groups like low, medium, high, but it's really important to actually look at the numerical value. And then this graph here is actually, you know, sort of reinforcing that, because each allergen is a little different. So when we're making healthcare decisions and making up treatment plans, we want to really personalize it to the patient. So we're looking at that patient's specific number to help us determine the likelihood of a reaction.
Okay. And then just to the frequency. So how frequently should you get this test done? What is the guideline?
So you should definitely talk with your healthcare provider, because it can be sort of an individualized decision. I personally, for example, with my milk and egg allergic children, since that allergy, there's a high likelihood that will be outgrown, I will actually order the test every year, because I'm constantly trying to decide, is my patient in the category of their likely or their trajectory looks like they're outgrowing the allergy? And if they are, that would be evidenced by, for example, if they came in initially and they were 6, and let's say that's like H1, they had egg for the first time, scrambled egg or something. And then over a couple of years, if they go down to this 0.6 or lower, or even better if they're negative, then I can take that information along with their clinical history. For example, if they've not had any exposures and they've not had any symptoms, then I can say, okay, it may be safe at this point to then go on to do an oral challenge. And so with milk and eggs, since it's likely that you can outgrow it, a lot of practitioners will choose to do the testing more frequently. But if it's something like peanut, that's less likely to be outgrown. So it's always a conversation with your healthcare provider as to the frequency. But milk and egg, I definitely do it like every year in the first 5 years with my patients, because I want to continuously monitor their status. If it's significantly lower compared to the initial value, then, and it's this 0.6 or less, then I can challenge them and potentially clear them of allergy.
And you said negative. The numbers don't go negative. You just mean the results say like
Yes.
0.
Yes. So positive versus negative is the lowest value that we level is 0.1, and so if there's if there's no detectable level, then that's negative. But it is positive if it's 0.1. The allergen is detected at a level of 0.1 or higher.
So if you have 0.05, we show up as negative.
Yes, we
Yes,
don't measure.
you don't measure it.
Yes, right. Because it's not higher than 0.1,
Right.
and so it would be negative. Yes.
It's negative. What about, we have a lot of teens, college kids, young adults, they're entering into this stage. We rely on them on our app, and we love them because they eat out a lot, they share reviews, and they're wonderful. If you're an adult, let's call it a young adult or adult, is the recommendation, is it the kind of thing that, maybe you have peanut and it's unlikely you're gonna outgrow it? Is there any reason to retest on any frequency? I can only share, we try to test every year. And although I'm going to get our component testing done, we haven't got it done completely yet. We'll want to have more information to determine that. People, it gives us hope. We want to get we're rooting for the numbers to go down. And is there any reason, particularly as an adult living with food allergies, is there any frequency you think you would recommend as a doctor? Is it never again, or is it once every 5 years, or any?
So with my patients, initially I'll test them more frequently, and then I'll test them if the allergy is persistent less frequently. And in the case of peanut, approximately 20% would outgrow it. So if I have multiple positive levels, then I know that I can then test less frequently. Now, as far as the number, for me, I would test maybe in a 3 to 5 year range, because I already have some values that have been persistently positive over a shorter period of time, so then I go to a longer period of time.
That makes perfect sense. I was once told by a doctor, I think we addressed this in the piece, is there any times of year or a menstrual cycle or any other factors that could alter the test results?
So this comes into play more so when it's pollen season. So pollen season, let's say you're allergic to tree pollen, let's specifically talk about birch. If those trees are out there blooming and you have exposure, then your numbers for birch could be higher. And so that's a good example of how, the environmental portion of it, being exposed to that, then the value could be higher. But that concept doesn't exactly translate over into food.
Okay. I want to go back just for a second to total IgE.
Yes.
So we have the specific IgE, and that's specific to the allergen. And then, for a while, actually, we weren't even told our total IgE, and we started asking for it.
Okay.
And so, there's this other thing called total IgE. And so, total IgE related to specific IgE, is there anything else we should think about? Should we pay attention to total IgE? How should we think about it? Because I hear a lot of friends say, our total IgE is, off the charts, it's this number, and then the question is like, what does it actually mean?
Yes, so total IgE, since it's the total amount, it doesn't mean actually much for specific IgE. So this is sort of a debatable topic, because when you're talking about food allergies, some clinicians will use the specific IgE to, let's say, milk over the total IgE and look at that ratio over time, and if there's a significant decrease, they may use that information to then decide about food challenging. But this is not well established. There are established guidelines based on clinical studies, and so we tend to refer back to the established guidelines as opposed to ratios, because that's not standardized and well established.
Going back to this idea that like 20% of people with peanuts will outgrow it, is there a standard for like by what age? So my daughter's 15. I'm kind of assuming she's not going to outgrow it. So is there an age that's that 20% outgrow? Could you outgrow it at age 30? Could you or most?
Yeah, when you're older, it's less likely that you would outgrow it. But when you're younger, it's more likely that you would outgrow it, and that's why in the first sort of few years of life, it's monitored more frequently. And then as you get older, like 7 to 8 years of age, then it's monitored typically less frequently, because there's less of a likelihood of you outgrowing.
Okay. So now we want to talk about accuracy. So, I can only share my own personal experience. My daughter's had a skin test and a blood test, and it showed not allergic, did a food challenge, and she reacted. That's called is that the false positive or the
false negative?
False negative.
If I understand correctly,
Thank you.
because it's very confusing, so I'm right there with you. So false negative is when your testing is negative, but you actually have symptoms of allergic reaction. Now that is very rare. It happened in your daughter's case. And that's why this testing is meant to be interpreted in a context of the patient's history. So I'm sure your daughter, before the testing, had symptoms that then led to the evaluation of testing. But then your doctor didn't just stop right there. They then used that information to try to predict a reaction. And unfortunately, she did have a reaction. That's rare, but again, that's why there are multiple levels to come up with a diagnosis. So you're using clinical history testing, but then to actually, see if the patient's food allergic, we would actually have to give them the food, and that's oral food challenge under doctor's supervision, which is typically an allergist.
So, one of the things I just jumped in my own personal experience, I'm sorry because it was scarring, but I think one of the things is the question is how accurate are the tests, and is one test more accurate than the other, and is it 100% of information you should be able to get from the test, which you're saying no, it's a data point for sure, but there's also the patient's history.
Exactly.
And
the testing, both skin prick testing and blood testing, are meant to aid in the diagnosis of food allergy. So that's why it's so important to get that detailed history plus the physical exam, but then also test results so that you can interpret the results within that context of a clinical history.
Okay.
And then you can arrive at a diagnosis.
Okay. So one fringe case is a false negative.
Yes.
There's also another kind of edge case, which would be a false positive. Can you explain what a false positive is?
Yes. So false positive is the results are positive, but you're actually not allergic to that food. And so one of the things to help minimize the likelihood of getting a false positive is that I come back to that clinical history. It has to be detailed. When you eat food and you have a reaction, it's not like you ate just one food. It's usually a combination of foods, and that's why it's so important that you have a reaction to, try to remember all the things that you ate prior to it, if we suspect food allergy, and then even retrieve the labels and have that all available for the doctor, because then the doctor can or the healthcare provider can go and order the specific IgE to those food allergens. And that would help minimize the risk of a false positive because you're interpreting the results within the context of the history. And then another thing that helps with false positives, and we'll talk a little bit more about this when it comes to component testing, is that there are different parts or specific proteins within the whole allergen that cross-react. So meaning that they look just like other things. So when it comes to hazelnut, it can also look like birch tree pollen. So then you might come up as positive, but is it that you're truly at risk where it's likely that you have an allergic reaction? Or is it more that you would have sort of milder symptoms just like you would if you were exposed to birch pollen? So that is what components can offer you to help better refine the diagnosis.
I just want to jump to components because it's really exciting, but we'll hold off, we're almost there. And so then back to like the accuracy. So there's kind of like, there's this case where you may get a false positive, there's a case where you can get a false negative, and you can kind of pursue to kind of refine that. Then there's the bulk of everybody else. And so I just want to confirm what you're saying, like it is this gold standard of testing. It provides a data point. The more information we have, the more detail we get, the better, we have more insight. But it is one piece of the puzzle. Right. So
that's a good analogy. It's one piece of the puzzle, and we're looking at multiple pieces to put it together and arrive at a diagnosis. Because again, if you're allergic, we do not want to give you the food. But if you're not allergic, then we want to see if we can give you the food because we don't want to hold you back.
Right, especially with some of the new guidelines about preventing, or to introduce. Some of the, I'm one of those people who was told don't give your child any nuts. My greatest issue was 3. I gave her the nuts at 3. She had an allergy. She was allergic, anaphylactic, and then now the guidelines are such that you're giving to infants, basically different guidelines at a very young age, and so the science is kind of flipped that you don't want to avoid it. Right, if you don't need to.
And so when it comes to early introduction, that is one of the cases in which we actually testing can be recommended prior to introduction. So the National Institute of Health recommends that if your child, or your infant, if your infant is high risk, meaning that they have eczema, moderate to severe, or if they have an egg allergy, then they should be tested prior to introduction of peanut. And now we are the mindset and the guidelines by the American Academy of Allergy plus the American Academy of Pediatrics. They do recommend in these high-risk infants that they get tested prior to introduction because we do want to introduce peanut early if it's appropriate. So I know we didn't always say that, but now we have the data to support that, and those are the recommended guidelines.
So if your infant's in one of the high-risk categories, I think there's a lot of people who, especially if you know some of the food allergies, or it's like your family member, maybe even had team members at Spokin who have had infants, and they live with food allergies all the time, and so it's a little nerve-wracking.
It is.
Right.
It's very nerve-wracking, and let me tell you, I have a 9-month-old. And the first time I gave her peanut, I was sort of like a nervous wreck. Because again,
sitting outside the yard.
and I'm an allergist,
right.
And so it's very scary. But we now have data to support that early introduction could be a good thing. But if they have eczema or an egg allergy, we want to test them before. And so we want to determine their status before actually introducing the food.
So in those cases, if you had a patient, like let's just talk about peanut for example. If you had eczema and the infant has the IgE test, the IgE test work for infants, I assume.
Yes.
And so the infant takes the IgE test and you have a negative for peanut, for example, and you would have some comfort that it's okay to try to go ahead.
Yes, you would discuss that with your healthcare provider, because some healthcare providers will say, okay, based on this child's history, then we could potentially have you introduce it at home. But then depending on their eczema, if it's really bad, then they can say come into the office and the child will have the first introduction of peanut, and when it's an infant, we're talking about 4 months or older, because it's important that other solids are introduced prior to, you don't want your first solid to be peanut, but then there are things like peanut powder that you can mix in a baby food they've already had, and then you can give it to them either at home or in the office, but that's a decision that you would make with your healthcare provider after receiving those results.
Sure, that's great. So we're going to switch to component testing, which looks a little complicated, but we're going to have you here to walk us through and make it easy.
Yes.
And I think, at the highest level, component testing, I'm going to let you describe it, but I think it's one of the more exciting things.
Yes.
I will say that we've, done some tests with our own audience, and there's a lot of people who don't even know what it is, or they've heard of it, they don't understand what it does. And I think, I'm a huge fan of trying to be the most empowered that I can as a consumer, as a mother. More information is always better. And I think that I have had a number of allergists. We love our allergists, but you get about 15 minutes, let's say, with the allergist, and you are discussing things like, my daughter is going on a date, or we want to leave the country, or should we use this auto-injector brand, or should we switch, or let's talk about treatments and therapies. And all this time goes by, and you may not have asked the question, or the allergist may not have brought it up. I like to make a short list for myself when I walk in, like, these are the things I want to cover. And we have an upcoming appointment. I got component testing right at the top. So you just, I'm so excited about it, because I feel like, as wonderful as IgE testing is the gold standard, I still want more information.
Yes.
And I still know, we're all familiar that people say, we have a mild allergy, we have a severe allergy, there's, all ends of the spectrum. And in some cases, it's based on, actually consuming the food and seeing how your child reacts. I know many people who have had very mild reactions only to have a tremendously severe reaction at a later stage. And so I even think even your history isn't really enough. How your past reactions don't indicate like future reactions. And so more information is better, and I think we're all hungry for more information. So as I've learned about components, and we're realizing that so many people didn't know about components, I learned in talking to you all that there are components for tree nuts, which I did not know. My daughter has a tree nut allergy. I did not feel like a good mom that day. However, it's a new day, and we're really excited to let you tell us a little bit about what it is, what it can test for, and then we'll dive into some specific allergens to give more detail.
So to give you like an overall view of components, so you have the whole allergen, and then you have parts of the allergen. And there are some parts of that allergen that are very unique and specific, and they're also known as storage proteins, and they're more likely to give you a systemic reaction. There's a higher likelihood that you would have a systemic reaction, and that's over here in the red. But then there are some other parts or proteins or specific proteins that they're called lipid transfer proteins, and they're sort of, they can give you a local or a systemic reaction. They're sort of not as bad, to put it in more simplistic terms. And then there are some that's sort of in the middle. I was talking about that example of hazelnut and birch, and you could potentially have a reaction, but it's probably very local, mild reaction. And then there are things that are cross-reactive. We say like they're ubiquitous. They're in a lot of things. They're in a lot of plants. And then it's less likely to give you any sort of reaction. But all of these could give you a whole positive test. But it's important to dive in a little bit deeper and look at the specific parts to assess risk. And if you're over here in the red, then that's a higher likelihood of having a systemic reaction like anaphylaxis. But if you're over here, it's lower risk. And so using components helps to refine the diagnosis, because you're taking in more information. And then of course with more information, you can sort of individualize the treatment plan.
So before I move on to some of the other, to explain this a little further, just on the most basic level, when you get your IgE test, let's say you get a numerical number, that is, you get a 5 and I get a 5. Let's just say to peanuts, or milk, let's just stick with milk. So we both get a 5 to milk. And it's what drives that number 5, based on these components. Your components could be over here.
Yes.
My components could be here.
Yes.
And that's why, me having milk with a 5 numeric number and you having milk with a 5 numeric number is not the same.
No, right, exactly, Susie. So the way that you explained it is great. So you can have a 5 and it can be driven by those storage proteins or those things that are, those parts that are very likely to result in anaphylaxis, or it could be driven by things that are sort of more ubiquitous and less likely to drive an allergic reaction, or it could be a combination of both. But then if we have to weigh it out, weigh it, we're always going to say if those storage proteins are there, no go for introducing the allergen, because that's associated with higher likelihood of having a systemic reaction like anaphylaxis.
Okay, so we're going to switch to the nuts. We have a chart for nuts, and this is.
Let me stand up to go.
You can stand up, look it every way. The idea here, what we have is, this came from your company, was we have examples here of peanuts and some of the tree nuts that there's component testing for, ones that I did not know about. And here, they actually have names. So the storage proteins are the ones that if you have are the most likelihood of a severe reaction.
Yes.
And you want to know if you have them. And there are actually specific names by each of these nuts. So I'm going to let you explain this.
Yes, so in that corner over there under storage proteins, for example, for peanut, there are proteins called ARA-H, and then it's 1, 2, 3, and 6. Those are very unique to the peanut. For example, if peanut were heated, like in the form of peanut butter, they would sort of stand strong. They would not be broken down. And these storage proteins can really rev up your immune system, and they're very unique to peanut, the ARA-H 1, 2, 3, and 6. And so in that revving up your immune system, they can cause your allergy cells to fire off throughout your body. Now there are other proteins there. I'll move to ARA-H9. Now it's sort of unique, but not as unique as the storage proteins. And then, therefore, it could be associated with a local reaction or a milder reaction, or it could be associated with a severe reaction. Now we see the severe reactions less commonly in the US. We see them more commonly in the Mediterranean, and that's because there's a lot of cross-reactivity with mangoes, peaches, nectarines, and those patients could react to sort of stone fruits plus peanut. Now we move on to ARA-H8, and it's more likely that you would have, if you have any symptoms, they would be more local, because again, that ARA-H8 looks like pollen, like the birch pollen, and so again, if you ingest it, you could get some mild, maybe itching in your mouth, but it's less likely you would have any systemic symptoms. So for example, if I have a patient who is negative for storage proteins on their component testing, they're negative and they're only positive for ARA-H8, I could have that patient come back into the office and do an oral challenge. I've done that before where all the rest of their testing is negative for components, but the ARA-H8 is positive, and they've gone on to pass the oral challenge. So, and there are studies that have been done. I have personal experience as an allergist with that, but then there are also studies that have been performed, and they tested multiple patients, and they see similar findings.
So when you get your test results, if you got a component test for peanuts, would it actually tell you, how would it list it? Would it say your ARH2, would it say positive? Would it actually list all these components, or what is it?
Yes. So with the component testing, it'll have the storage proteins, so they'll be listed separately. And again, just like with the whole IgE testing, it would give you a numerical value. And so you're going to get a numerical value for each and every storage protein, 1, 2, 3, and 6 of the ARA-H's, and then ARA-H9, ARA-H8, and then we recently added the CCD and our peanut profile because we wanted to be able to explain when you have a positive, whether it's blood test or a skin test, what's behind that? Is it the storage protein that's a higher risk of anaphylaxis or higher likelihood that you would have a systemic reaction? Or is it something that's more cross-reactive? And then looking at the components in that context can help you make that decision as to whether or not you can go forward. It would help inform the decision as to whether or not to go forward with a food challenge.
So you talked about, we don't have a chart for it, but we talked about kind of when the protein is heated and what happens to it. When we think about milk and egg,
Yes.
which, you know, when someone has milk or egg, we know that they're most likely to grow out of some of the other allergens. But you have a lot of people saying we can have baked, we can have baked. And so I think when you look at the components for both of those, which are detailed in our piece, in our feature, when you look at them, I think like casein is like the name for the one within milk. That's, you know,
yes, if casein is high, that protein does not become denatured or broken down by heat. So then if casein is high, a high component within that milk whole allergen, then you want to avoid milk in all forms, baked and non-baked. But let's say casein is low, or let's say casein is negative, but then lactoglobulin or lactalbumin are positive, then those are denatured when it's exposed to, when they're exposed to heat. So then you could potentially tolerate baked milk products, but then the final step in sort of that evaluation is actually to do the food challenge. So these components are helping to inform the decision for a food challenge.
That's so helpful, and I think like when we look at where the component tests, can you tell us which allergens are component tests offered for?
So they're offered for milk, egg, peanut, and tree nuts.
And so we see the tree nuts here, it's hazelnut, walnut, Brazil nut, and cashew. But if you tested for cashew, that's indicative, I think, of also pistachio?
Yes, so if you test for cashew, cashew is highly related to, or what we say associated with pistachio. So if you come back positive for NO3, which is associated with a higher likelihood of having a systemic reaction like anaphylaxis, then that would also apply to pistachio. So you would actually avoid both.
Understood. And so it seems like when you're going in, I mean, would you recommend, if you're going to see your allergist, well, one of our recommendations, one of our tips that I've learned from my many years of being a food allergy is I always ask for the test to be done before I see the allergist.
Yes.
Because I really want to be with my results after because we don't have time for 2 appointments.
Yes,
So, you know, one of my tips, and I remember talking to some people when they're newly diagnosed, not your first appointment, but when you know you're going back and you're revisiting your test, ask for it beforehand so you can walk in. Maybe everybody does that, I don't know. But like when I learned that, that was so helpful to me.
It's very helpful to call your physician maybe a week in advance and then request the testing. So then that way the test results would be back by the time you go in, and then they can pull up the results and you can discuss them right then and there. Now, some of the other tips that I give for my patients is, for example, if they might have had symptoms consistent with a new allergy, because that would be a reason to test for other allergies as well, then I would have them take a picture of this chart, and then so when I call them, I can then walk through the results with them. So if your physician has guides and things like that regarding how to interpret the results, taking that snapshot and then, you know, potentially a follow-up call would be useful as well. But I definitely use your tip, and I tell my patients about that. You know, call me a week in advance, I'll order the testing, and then that way we will have the test results right then and there.
Okay, and you also shared another tip with me, which I definitely want to share because it's something I learned new. If you're going to get your component testing, you can ask for with
reflex testing. So this has, you know, I see a lot of patients, kids, and sometimes it can be hard to get the blood draw. And so, for example, if, let's take for example peanut, if the whole allergen to peanut is positive, there's something called reflex testing where you would automatically get those components generated. And so this is important because I can call you and say it's positive, but then I would have to do a separate blood draw for the components. But if I get reflex testing, as long as it's positive, then automatically those results would be brought in.
Okay, this could be one of the more important things. I have a child who will pass out from blood testing, so and I don't think anybody likes it, and it's time consuming, and there's enough anxiety that can exist with food allergy. So we can as patients say to our allergists, what we want is our blood testing, our IgE testing with reflex. And we're going to ask them, they're going to say, what does that mean? And we're going to say, we just want to make sure that if you're going to get the IgE testing done and there's a positive result and component is offered, that we can then, they can go the next step, run the component testing, and then we can have those results.
Exactly.
Okay,
Yes.
that's super helpful. I mean, the other tip that I have is keep track of your IgE tests in one place, like in a Google Doc or a spreadsheet, so that you have them so you can go to the doctor and have those all with you. One question about component testing, just a few minor ones. Is it like IgE? If you get component testing, can this change over time? Is this something that you would also potentially revisit, or is it fixed?
You can revisit it, because again, let's go over the example of milk and egg, as I stated before.
Yeah.
Milk and egg allergy you can actually outgrow, and majority of kids will outgrow it. So then you can continue to monitor the components for those allergens. And so based on those components, for example, if casein's negative, and it was positive, and then it goes negative, and then the other ones, the lactalbumin and the lactoglobulin are positive, then your child may be eligible for a baked milk challenge. And then if they do well with baked milk and those other numbers come down low, then they could potentially have ice cream and then open up milk in general. And so it can be an evolving story, particularly with milk and egg, because those are more easily outgrown.
Can I go the other way? It's not a big fair question, but can you get where your ARH, you don't have one of the storage proteins, and you're 4 years old, you don't have one of the storage proteins. Could there be a scenario where later at 5 or 6 you then do have the storage protein, or is that unlikely?
So what I will say is that, so for example with the ARH8, right, if you did blood testing or skin testing to the whole allergen, it would be positive. And then you get the components and the storage is negative, right? That's the example. But then let's say ARH8 is positive. Then you do want to test at that point in time to clarify, because it's an evolving story and you can develop allergies at any time. So that's why it's so important to monitor the status at least more frequently initially, because this is an evolving process. And then if there is a situation where you're lower risk, you want to discuss with your doctor pursuing oral food challenge, because you don't want to be held back or avoiding the food unnecessarily. Because if you go long periods of time and you don't take advantage of that opportunity, it could change.
And how long do you have? Because I can share with you that we've seen many allergists who's really hard to get an appointment with. There's a lot of us food allergy people out there. And so if you get your test results and you want to then, let's say your allergist is recommending a food challenge, and you're saying you kind of want to do it because the story can change. If you can't get an appointment for 3 months, is that okay? Is it like, as far as like what's your period of time?
Yeah, I would say that, of course it's always best to get in, within 3 months. But, any healthcare provider can order, the testing. If there's sort of unclarity regarding, your whole allergen testing, and your doctor feels like, well, I don't know exactly what to do here, the safest thing would be, to, of course, clarify what you should avoid, and then get that allergy appointment for as soon as possible. And typically, patients will wait about 3 months or shorter to see an allergist. So I think that's a reasonable time for a referral for an allergist.
So we had a question, and it came from people in the audience through this question, and we addressed this question in the piece. The question is, what if my allergist doesn't offer component testing? And do all allergists, even if they don't talk about it, is there still the potential to get it? So do they all offer it?
So many of them do, and many of them are familiar with component testing. So again, it's a conversation. You should feel empowered to ask about it because as I'm explaining, it offers more information. But really, any healthcare provider can order the test if they're authorized to order testing.
Okay.
So it's a conversation that you should have with your healthcare provider.
That's super helpful. And then as far as, I don't know if this is something you can, if you know about, but as far as, does insurance cover component testing?
Yes, so most often, it is covered, but again, it's based on your individualized insurance program. So I tell patients, you as a precaution, you could always call your insurance company to ask, but most insurance companies do.
Okay, so we're going to switch gears to another topic, which is food intolerances versus food allergies. And we know there's some home tests out there that are, testing for food intolerances, but could you just kind of at the highest level explain the difference?
Yes, so food allergy is one that could evolve to severe allergy, including anaphylaxis. And so the common symptoms are like hives, shortness of breath, wheezing, stomach upset, diarrhea, vomiting, any one or combination of those symptoms. And that's IgE-mediated food allergy. So that's what we think of when we're talking about food allergy. Now there's food intolerance, and those symptoms typically are limited to gut symptoms like stomach upset, like bloating or cramping. And so those are two very different symptom spectrum. And so when we're talking about food allergy testing, we're talking about the IgE testing. And food intolerance, there's no approved testing for that. And the American Academy of Allergy does not recommend IgG testing. Although you may see that advertised as food intolerance testing, there's no FDA approved food intolerance testing.
Okay, great. So we have time for maybe one last question. We've tried to weave in some of the questions that people have been asking. One last one just to ask you is we hear about patients who have oral allergy syndrome. We hear about that one a lot, that they have this localized reaction in their mouth. And I think we have a question like, and I don't know if you studied that, if you know much about that, if you can talk about that, but one of the questions is there any correlation between that and developing new allergies?
So if you have oral, you can develop, the thing about allergy, which is unique, is that you can develop at any time. And so when I mentioned the component testing, you do have things like ARA-H8, right? Which I said, it's within peanut, but then it also looks like birch. And so you can get some itching in the mouth, and that would be a localized symptom. And so it's very important to discuss with your doctor your symptoms, and they can decide if testing is appropriate. And then you can be more informed as to what this status of this allergy is. It's really taking that good history and then doing the testing to then arrive at a diagnosis of food allergy.
Okay. Well, you've been so generous with your time. A lot of this has been covered in the piece. We wanted you to talk to us how we talk, though. We want to have some just natural language to explain to us. You obviously interact with patients. You're a mother, and I know how we want it to be explained to us. So there's a lot of this. You guys can take a look at the piece. Our content team did a fantastic job. You guys have been so wonderful to answer the questions because you are the ones we want the answers from. And we know that the doctors are trained on interpreting it, and we, there's not a lot of time often with the doctors. So we felt like if we went to you, you guys are the source. The gold standard of IgE, specific IgE testing, and it's so helpful. And I can only share for me, the piece is really helpful. I've had to refer to it several times. There's a lot to take in. That's why we wanted to put it in a piece that people can refer to. I'm getting my component testing. I'm going to ask for my IgE testing with Reflex. Reflex, did I say that right?
Yeah, you got it.
Okay, and get more information, and we're excited. Thank you for joining us.
Thank you, and I will say that if you want more information, you can also go to Allergy Insider because we have great educational tools to help you interpret your testing and help you even determine those questions that you should ask your healthcare provider.
Yes, it's a great point, and we've linked to Allergy Insider. It's a consumer-facing site that Thermo has put together. It's chock full of information.
Yes.
We've linked to it in the piece, so if you have an issue finding it, just go into our piece and you'll find it. Thank you so much.
Thank you for having me, Susie. Thank you.
Thank you.